Good evening. Welcome everyone, and thank you so much for coming along to join us this evening for an hour of discussion with Rob Campbell. My name's Marie Bismarck. I'm a Professor of Public Health from the University of Melbourne. Rob has been a close colleague for nearly 20 years now. We served together...
Making me sound old.
Making myself sound old. We served together on the board of the Accident Compensation Corporation and then together on the board of Somerset for many years, and I feel incredibly privileged to be invited to host this conversation with Rob tonight. So Rob probably doesn't need any introducing, but I think it's fair to say that he is one of the smartest and most complex people I have ever met in my life. So Rob started work as an economics lecturer at Victoria University before becoming involved in union negotiations. He then went on to be a corporate economics consultant before turning his hand to directorships, which was a skill that he was incredibly good at. And as some of you may know, Rob has chaired some of New Zealand's largest companies, including Sky City, Tourism Holdings, and Somerset. He was recognised by Deloitte as New Zealand Chair of the Year and was awarded a Companion of the Order of New Zealand Merit for his services to business in New Zealand. But it's probably for his role as Chair of Te Whatu Order, a role which Rob held for around 18 months, that most of you have come along tonight to hear about. So welcome everyone. The format for this evening is that Rob has some comments which he would like to share with us, and then after that Rob and I will engage in a conversation until the evening wraps up at about 6:30. We won't be taking questions from the floor, but some of you have had a chance to meet with Rob already, and I hope that some of the questions that I ask will answer some of the things that are burning in your minds. So thank you everyone, and thank you so much Rob for coming and sharing this evening with us.
Thank you, Marie, and ever since I started in this health gig, I've got very used to being the person in the room that knows least about the topic that we're talking about, and that's certainly true tonight with Marie on stage with me. So thank you for the opportunity to discuss the Paora health reforms with you. Since I was sacked by the health minister, I've taken the time I've had to reflect on the experience and to make a considered assessment of what I learned in the process. And my intention tonight is to share that with you, making the assumption that we share common ground in wanting to have an effective, efficient, excellent and equitable public health service. If anyone doesn't want that, I really don't have anything useful to share with you, so it's very much directed towards that. Similarly, I'm not going to spend any time listing the many things that are wrong with our public health service and its outcomes. That's been done often enough in research papers and media commentary, and it's been experienced more than enough by whānau throughout the country. Enough to make it clear, in my view, that we have sufficient crises in different aspects of public health care to declare a health crisis which is worthy of a crisis response. And that is so despite the many excellent things that are done every day within the public health service by many skilled and dedicated people. So please don't interpret anything I say as being critical of the work that is done by those people. So if anyone doesn't think that we have a health service crisis, then again, I probably don't have anything very useful to share with you, because that's a fundamental assumption. What I'll do is start with a quick summary of, first, the important aspects of the Paora reform package, which in my view are not adequate to the task. Secondly, the significant ways in which the implementation to date of the reform package is defective. And thirdly, note that that's not and shouldn't be accepted as being incapable of repair. So I believe there is a path forward. I'll cover each in more detail, but first I do want to summarise a view to make sense of what I'm going to say, summarise a view of effective social service change which I'm going to apply, which is derived from my my experience over a pretty wide range of social government and commercial activities. It's not a revolutionary view, you might even call it Fabian as to how I want to proceed. And that view is that to reform a health system which is in the level of crisis that ours is, requires a substantive social change program. It's not a technocratic or a managerial issue, it is a social change issue which has to be undertaken. And to achieve a social change program, you have to have 5 things. First, a clear and shared view of what the purpose of the change is. Secondly, leadership and strategies which are consistent with the change purpose. Thirdly, a realistic appraisal of the environment in which change is to be effective. Fourth, a sound understanding of the issues for and the ways to involve people affected by the change. And finally, effective ways to communicate about the various elements of the change in all directions. And what you'll hear as I work through my thoughts is that I do not think that the Paora reform process has that based, and it now has to be reconstructed or fail. In my view, we can't let that happen. I'll start with what I think the architects of the reform got wrong. And as you all know, the architects were largely people in central government or people contracted to provide them with advice. First, removing structures like the DHBs and the various shared service agencies without clearly establishing or even signalling replacement structures at national, regional and local levels. That meant that all those levels were left too poorly defined, and it created confusion and led to excessive centralisation, or at least the perception of excessive centralisation. To repair and establish appropriate standards, accountabilities and systems, a high degree of centralisation was required, but it was short term. And that didn't mean that systems of local and regional involvement and influence were not also required. It's a critical fault in the legislation. Secondly, adding poorly defined new structures, such as localities and iwi Māori partnership boards, intensified this. While conceptually these could deliver that critical local and regional involvement and influence over time, in the short term they're unable to do it, which leaves a gap until they are being established, which showed an unrealistic appreciation of the environment for change. Third, the inadequate involvement of the unions and professional organisations in the structuring and implementation process restricted both potential support and clarity of roles. This ignored both the historic influence of those organisations and their potential, which was willingly available, to guide decisions in tune with the reforms and to enable implementation. That showed an inadequate managerial lack of appreciation of the necessity for active, positive engagement and hampered the reforms from the get-go. Fourth, carrying through all the old roles in management added confusion and cost and limited real commitment to the new structure. The same people in the same or essentially similar roles leading change showed an inadequate appreciation of the scale and depth of change that was required. It also restricted their capability to quickly drive any level of culture change. Fifth, the failure to define and structure quite different functions within the total Te Whātua organisation, and I just use as an example property development, operation and maintenance, the failure to separate those into separate organisations hampered focus in those roles and in the wider structure. This was compounded by not undertaking a prior thorough revision and reprioritisation of capital projects to match the new structure and direction. For example, when our board started its work, we were explicitly instructed that all existing capital projects were to be completed, which is roughly 10 years worth, before we would have ever got to doing anything new with capital expenditure in the system. Sixth, and this matched that lack of appreciation, allowing IT project strategy and promises to be far too aspirational and too complex, way beyond the limited capability of inadequate existing systems, and their renewal and repair, which simply had to be the initial focus. Getting a system that actually worked was far more important than some of the grandiose dreams being dreamed up in Molesworth Street. Seventh, the failure to define a new model for funding and support of primary services, working with those services ahead of the establishment of Te Whatu Ora, was a critical error because it obscured a clear view of the purpose of change beyond aspirational slogans about what we would do, and limited the ability to engage primary services again right from the start. Critically, failure to resolve major issues such as pay equity, pay parity, holiday pay, and primary care funding, all of which were known and all of which had been scoped and all of which had been defined as part of the initial package, meant that that was left over to the new organisation to deal with. Ninth, and you'll be pleased to know the list of these terrible faults is about to come to an end, imposing structures on Māori which stepped past existing sector structures such as whānau ora and kaupapa Māori providers who were already in existence, was not driven by iwi and hapu, took only very limited account of Māori health views and worldviews, while not providing anything like the funding and power necessary to enable any level of mana motuhake or tino rangatiratanga in the Māori side of the health reforms. And then finally, and to confuse it even further, failing to properly define the levels of accountability and role for Manatū Haora, the Ministry of Health, and other organisations, most of whose work is really good, but who were somewhere lost in the mess of the initial reforms, like the Health, Safety and Quality Commission and other health sector agencies, all had to be restructured together in a sensible way and aligned to the reform purpose. So all of those things were obvious at the start of the Paora reform process, and all were critical constraints. Simply, there was too much which was undefined, too much not rooted in stakeholder support or even understanding, too much which was old form public service delivery in style and content, too much which limited efficiency and clarity throughout the system. It might have looked okay on a whiteboard, but in practice, it looked like the half-baked cake it was. If there was any level of consumer guarantee in the contracts for advice from the consultants involved, you'd be calling on it now. I won't focus tonight on co-governance, although it's popular or unpopular, but I do want to say that the Paora reform is very far from either this concept or from treaty-based governance and management. Te Whatu Ora and Te Akawhai Ora do work together in common interest, but Te Akawhai Ora is a creation of the Crown, not of Māori. It should have had much more independence, money and power than it has. Its excellent leadership will make the best it can of what it has, but no one should think that this is enough, good, or good enough. Now, it was possible for Te Whatu Ora, once established, to implement change, even allowing for these things, but having to grapple with them all simultaneously was too much. Those of us who took on board roles did so with genuine commitment to the kaupapa, but with reservations about the structures from the beginning. For myself, as my understanding of the health system grew, it became evident that our challenges were huge, given the gap between aspiration and reality. And this became very intense as we battled our way with government bureaucrats in the ministry and DPMC to a highly compromised Pai Tata, or interim health plan, tried to generate activism and accountability against a reluctant management structure, and negotiating ongoing top-down controls based on past principles and practices from ministry and other officials. In practice, the structural issues with the reform package were not much helped by mistakes we made in the implementation process. There's a list of these too. First, Te Whatu Ora remained excessively focused on serving Wellington in its broadest public service hierarchy sense, and not on the real needs of clinical and care providers, or even more crucially, the wider population. Secondly, we did not involve unions and professional organisations in the implementation process, even to the extent that was possible after commencement, treated them and continue to treat them as something to be managed. Third, we treated the funded primary sector the same way and didn't engage effectively with them, listen to or involve them sufficiently in the process. Again, treated them as something to be managed. Fourth, we allowed roles and managers which were actively getting in the way of change to remain in place, rather than quickly and effectively changing or removing them. We were too slow to abandon behaviours which were not directly or effectively serving the cause of change. We didn't fight energetically or effectively enough against legacy projects which were no longer appropriate priorities. We didn't engage or communicate positively or directly enough with internal and external stakeholders about the change process, or encourage their effective involvement and influence. In short, and this is the core of what I want to say about Te Whatu became not a representative and advocate for those working in our public health service, but government's representative to them. My perception from board level is that there was a line of thought and intent to be more effective in this, but we were held back by too many managers at all levels who are indecisive or inadequate or even opposed in terms of being active change leaders. Second, a lack of political will from government above to embrace the necessary radicalism or urgency of change given the nature of the crisis we're facing. And third, far too many objectives or priorities, call them what you will. You may recall the planned care fast where a group brought back a report which one of our board members helpfully labelled the Dalmatian report, which had 101 recommendations which were never going to be followed. And what that has done is meant that many parts of the system, rather than having real clarity, left people feeling disengaged and confused. To me, it felt as if having created and passed the legislation, those in political control lacked the will to see it succeed. Now, I don't offer those things as excuses. The board under my leadership should have been much more demanding, resolute and courageous than it was. Timidity was not an option, especially given the structural inadequacies which are embedded in the system. So what should we do from here? I think that Te Whatu can and will deliver some changes within its current administrative managerial mindset, but in its current form it will not be able to deliver the level of radical change which is required. Inadequacies and things which are just plain wrong will persist and in many cases get worse unless there are substantive changes. Now, I don't say that to give any succor to political parties which want to turn back the clock or to deny equity, or to those who welcome further demise in public health services for commercial reasons. I say it because we all have a common cause in having a much more equitable, excellent, efficient and effective public health service than we currently have. And we need to do that, to have some practical changes which require the government and Te Whatu to do some things together. I'm not confident about these, but I know what they are. First, they have to recognise that localities are not a short-term answer to health service issues. We have to encourage interagency and community group involvement in the wider determinants of health, but this cannot be the key focus of primary health sector in the immediate future. Te Whatu needs to work with the existing agencies and models in crisis response. Secondly, we have to recognise the existing national, regional and local clinical networks as core to clinical service delivery, which management serves and coordinates but doesn't seek to control. Third, we have to create those separate physical and digital infrastructure operating units within Te Whatu with their own budgets and accountabilities, contracted to serve the clinical care and digital operating requirements of the delivery units. We have to involve directly the funded agency in urgent review of all their contracts and funding, many of which have not been properly reviewed for years, in some cases decades, and consistently apply equity and accountability systems. Effectively, in my words, we have to decommission the existing commissioning system. Fifth, in doing this, we have to directly involve the unions and professional organisations in all planning and governance processes at all levels. We have to establish a planned transfer of substantive funding to Te Whānau sufficient to support effective Māori health services. We have to conclude the various pay equity, pay parity and holiday pay issues. There are funding issues with this, but they're all things which are known and which we will meet at some time or another. Delay is simply harmfully delaying the inevitable. Then we have to implement properly the internal restructure to remove duplication and multiplication of roles from the old structure and transfer resources to where they are most needed. While consultation on this has started, it's been far too slow in development. It's had far too little staff involvement to date, and the most important thing is those sorts of restructurings are not an exercise on their own, but an integral part of the group of major initiatives I'm talking about that you can involve people in and work with them for. And the same applies, for example, to training, retraining and recruitment steps, which require a lot more attention. Critically, Te Whānau has to begin to prioritise known public health initiatives which will impact demand for its ill health services. It's got to be bold about alcohol, about sugar, and about the other determinants of ill health in the same way that smoking has been attacked. It's got to back that up with genuine public health campaigns which actively deliver services where they're most needed, not focus on running advertisements on television shows. We have to, I'm afraid to say, engage more positively and effectively with private sector, insurance, hospital and other services to define roles and to include them in the system objectives and principles. They are, whether we like it or not, an embedded part of our system and have to be part of the crisis solution. We have to be prepared to replace where there's not a satisfactory working together arrangement. It's not just a matter of contracting out operations to these people, but they're so significant in the total health package that is available to our communities, we have to fully involve them in all of the processes. The fact is that so much of what is public about our public health system has been degraded that we have to include them, but that doesn't mean an assumption that they all have to continue if they're not serving our purposes. Now, implementing that radical change program would require throwing off some of the public service procedures and rules. We've got to radicalise the process as well as the aims. Now, none of this is a panacea, and yes, it will cost a lot more money up front, and I'm coming to a conclusion. But we have found a willingness to act decisively and expensively when one-off external events strike, causing community harm. And this crisis is really no different other than its scale and its lasting potential for community harm. This could all be done with the political will to really follow through on the Paiora principles and with the governance and management, independence, energy and courage to carry it through. A lot of money up front is a fraction of what we will spend later in its absence. Now, we can learn from some of these experiences to date. For example, while the localities will not form clearly, quickly and effectively enough the main conduit for delivery of primary health services, the activity around them has confirmed how involved local people and their community organisations want to be in the future public health system, what they already bring and with the right process can bring to it. They've highlighted many aspects of effective health services and the social determinants of healthy whānau in communities, which require multi-agency response beyond what Te Whānau alone can bring. There is an opportunity to involve all central and local government agencies, which are largely ignored in the Paiora reform structure, I might say, along with the voluntary sector and common cause. Paiora can be a catalyst for that. It's exciting, but it requires us to adjust and to pivot. Similarly, the limited experience so far has highlighted the need to review how we interact with the private sector. I think that Taka Whaiora had some similar experiences and insights. I won't intrude on those, but we also have to be able to pivot around those. In other words, neither the inherent inadequacies of the reform structures or the failures of implementation need to hold us back if we treat them as learning opportunities. To effect that approach means stepping outside of the old public service controls and processes and being brave enough to do it, being brave enough to take risks. I think that one of the issues to date is a widespread perception that this political will and this governance and management commitment and capability is not there, that the process or significant elements of it will not be carried through. So what happens is that people prevaricate, they leave the system, they work on in disillusion. That has harmed us badly and will continue to harm if there's not more clarity in a collective leadership of change. If there is a will to do this, then we can use the Paora Charter as a guiding principle to which all participants are genuinely committed. That's not been possible to progress effectively in the environment and change structure that we've had to date. Change is sort of caught between the old order and ways of doing things which have produced this crisis and the unrealistic output from consultancy-driven restructure, but with determined insight and energy from the ministers and with a genuinely skilled and committed board and management working with rather than against other stakeholders, that can be done. I know some people who think one of the problems here is that there's been too much change already, but the truth is that we're caught in the middle at the moment. We've started the change which we either continue with and complete in a radical way, or we'll end up with potentially the worst of all worlds. It's simply a matter of recognising that this is a major crisis that requires major social change, and it's got to be implemented within a framework like that I identified at the outset, just to say, clear view and intent, capable and consistent leadership, realism about the environment, involvement of all people, and effective communication. Now, I'm hopeful that those involved can now see and act on that.
Thank you so much, Rob. There's so much food for thought in there. I think we could probably have a whole evening dedicated to any one of those comments that you've made. But I'm wondering if you might be willing to just take us back in time 18 months ago when you were first approached about this role, because I understand that becoming chair of Te Whatu Ora was not something that you applied for, it was something that you were invited to do. And I would just love to know what your thinking was when you received that invitation and what your motivation was to say yes.
Yeah, I was invited to take on the role and I didn't go through any process at all, which I guess might surprise some people for a role like that, but I was invited to take it on and said yes because I read the background material, and while I had deep concerns about some aspects of it, the basic kaupapa seemed like the kind of thing that we desperately needed, and it was hard to drag me away from running a casino into something so trivial as running a health system, but frankly I jumped at the chance to get rid of my corporate jobs and do this because I thought it was important.
Yeah, thanks, Rob. And just that comment that you thought it was important, what in particular was it about this kaupapa that resonated with you? Were there particular aspirations that really struck a chord with you at that time?
Well, it's a mixture really. So I've still got a bit of an economist lurking around in me. Sorry, Jeff, but I have. And so it worries me worried me that we struggle, those of us who believe in public services of any kind, we struggle to be as rigorous about efficiency and effectiveness as I believe we need to be. I think the people who really want to have public services should be the ones who are leading pressure for efficiency and effectiveness in delivery, not lagging on it. It's often left to the people who are actually opposed to public services to do that, and I think it's important that we are leaders in it. And there were some very obvious inefficiencies in the old structure. The DHBs, for example, had quite a lot of good things about them, but there wasn't a need for 20 there is enormous duplication in the system that's taking a long time to work out and lack of clarity. So that efficiency thing was a significant driver for me. Secondly, equity, it had become very apparent to me through other work I was doing in the community that the glaring and savage inequity of health services to Māori and Pacific people was simply not being addressed by the current system. Whatever words they put around it, whatever reports they wrote about it, it was simply being ignored and callously ignored. And so I thought there was a good opportunity to turn that around. I had a shallow Pākehā understanding of the issues on the Māori side of that. So I had some good intentions, but I had to go on a very quick learning process about how that panned out. But that equity thing was a significant driver. And thirdly, I was intrigued from what I already knew of the health service at the enormous gap that there is between really, really high levels of trust that I had never seen anywhere else. I went out and met a few people in the system, just not officially, just turning up and talking to them. And I'd never seen in my working career such high degrees of trust amongst the teams working in health, and I had never seen such a high degree of mistrust between them and the people that were managing them as I'd seen in health. It was a savage contrast, and I thought that there must be a way to do something about that.
Thanks, Rob. I was really interested because I know you did go out and meet with many frontline staff, and as we were speaking about just before this event, that's not just the doctors and nurses, but all of the other people who help to make a health system run, including all of the support workers and the peer workers and all the allied health staff. And that's such an interesting reflection that it was the highest level of within team trust, but yet this distrust of managers. As I was driving to work this morning, I was listening to an interview about pay disparity between New Zealand and Australia for nurses' wages. And it really made me reflect on some of the wonderful nurses I work for and why they come to work each day. And I just wonder if you want to reflect a little bit as you went around and met with the people delivering that frontline care, what you learned about their motivation for coming to work. And I guess it's partly a question about retention and attraction. What is it that keeps people working in this health system in crisis?
Well before I joined the health system, one of the striking things about managers and executives in organisations, be they public or private in my observation, is the extent to which they treat the people doing the actual work like rats in a cage, and think of them in terms, very simplistically, in terms of incentives, etc. Regard them as costs and people who can be simply incentivised by relatively minor adjustments in money. So money's obviously critical, particularly if you don't have it, and it is critical to our health workforce that we pay well, but I find a real deep realism amongst our health workforce about those offshore pay scales that are available. People know that New Zealand isn't a rich country, despite what the politicians like to tell them. They know what the realities of our environment are. And I think that if they perceive themselves to be treated reasonably and paid reasonably within the local context and involved in the process of determining how care is delivered, that in fact we can have a much more highly motivated workforce. But you can't do it by this kind of, we'll withhold it, if you behave we'll pay you more kind of attitude. You have to involve the workforce much more in the whole process. And I don't say that if you do that you'll get the labour cheaper, but I think you'll get far less disillusion than there is in the current health workforce. They want to be involved. Their organisations want to be involved. The best research, I kept saying to Sarah Dalton from the ASMS that in my view we should sack the policy department in the Ministry of Health and just use the ASMS research department. It's by far consistently the best output on health policy in our health sector, and there's some others around too in different parts of the industry, and yet that's not drawn on. That's treated as a kind of an external thing. You know, the nurses organisation, here too, the others, produce a lot better understanding of what is going on than happens in Molesworth Street, or indeed in amongst the other DHBs and DHB structures around the place.
Thanks, Rob. So a very clear message that the healthcare workers and other support workers wanted to be involved in the change, and you mentioned during your comments that you thought that local communities wanted to be involved in the change as well, that local communities care deeply about their health services and that they wanted to be part of this change. I'm just wondering about the mechanisms for that happening. While you were chair of Te Whatu Ora, did you feel as though there were mechanisms for hearing the voices of those communities and that the voices of patients and families could be clearly heard and able to influence policy?
No, I don't. I mean, there's some excellent work done on this by HQSC, frankly, and it's one of the reasons why I think that work needs to be more well integrated into the whole service structure of the health service. They do some really strong work. At the local level, the levels of community involvement and consultation were pretty perfunctory, to be frank, and the localities concept is intended to be the ongoing answer to that, but it is just naturally, if you think about it seriously, establishing those organisations around the country without having clearly defined the roles of GPs and PHOs and all the other services that are available is just a Herculean task. I think it could evolve over time into a really effective means of involvement. But, you know, we're heading in the other direction. I don't know how the government's got away with this, but, you know, during COVID, we learned that community level care and involvement was incredibly effective for many populations. The populations that we like to call hard to reach, until it was pointed out to me by one Māori woman working at Manukau not long ago that it's not us that are hard to reach, it's you that are hard, it's you that's hard to reach, and it's very true. But, you know, we built up that whole workforce, and then Treasury and the government decided it wanted to start cutting the funding because COVID was over. Now, there were two things wrong with that. One was that COVID wasn't over, but secondly, everything we had learned told you that that could have become, for example, the immunisation workforce. It could have been a whole range of other services. We could have upskilled that whole workforce, and what are we doing? We're laying them off. We're cutting the funding and laying them off, cutting back on what we knew had worked during the COVID experience in favour, and where's the noise from that, from the traditional health service? Completely dead on it. So, you know, we're going in the wrong direction, but that level of involvement, I think that in time, if they can sustain themselves, I think that, for example, the iwi Māori partnership boards could become very effective in that. I think localities could become very effective in that. But we have an urgent crisis that we have to do more about immediately, using the organisations that are actually there. Sorry, that was a bit of a rant.
That's what I'm here for. And such an interesting comment about COVID, and you sort of alluded to it in your comments earlier, where you said that New Zealand has shown that where we recognise the urgency of a crisis, we are able to act. And I think certainly our COVID response was widely recognised as being world-leading, and that we achieved extraordinary things by pulling together as a community. And, you know, looking back 5 years, it would have been hard to imagine that as a country we would have been able to achieve what you did. And so it sounds as though you feel as though we learnt all these lessons, but they're slipping between our fingers.
Yeah, I mean, I spoke to the ELT about this quite early in their tenure, and I was talking to them about how important leadership I said, forget about the E bit. You're executives, that just means you're paid a lot. Think about the leadership part of it. The leadership thing is that's important to you, and I probably misquoted Nelson Mandela on exactly your point to them, saying that what we fear is not our weakness, what we fear is our strength, what we fear is how good we can be at things. That's the real thing that makes us apprehensive. Right, we can do all that, and COVID showed what we could do in our communities. I also made the mistake in that same talk to them of referring to another doctor called Che Guevara, who in one of his famous quotes pointed out that it may seem ridiculous, but the true revolutionary is guided by the deepest feelings of love, which I still believe is true, and I think is true of the change agents here. But I think I lost the audience at about that point.
And Rob, this need for revolutionary change, is New Zealand alone? I'm really curious, in your time as Te Whatu Ora, did you have an opportunity to speak with counterparts in other countries? I certainly see healthcare workers in the NHS and in the United States talking about a crisis in their healthcare systems. Were a lot of these reforms looking very much inwards to New Zealand, or did you have an opportunity to reach out and connect with other healthcare leaders around the world to understand how many of these challenges we share in common?
Yeah, I did talk to a few, and you know I'm a reasonably voracious reader, so I read a lot about them, and a lot of the issues are the same, and, frankly, the consultants, and it's not all EY, but everyone got their bite. They didn't sit here sucking their thumbs and think up a new structure. They thought about exactly the same issues that their colleagues are dealing with in other countries around the world. So there's enormous similarity about what is being done. There are some differences, but I think at that much bigger macro level, there's been a substantive shift in, let's call them Western countries, not a phrase I like much, but let's call them that for the moment. There's been a substantive shift in the nature of demand for healthcare, both in terms of age of population, in terms of inequality and the different patterns of demand that drives, a whole range of things. So there's been a substantive shift from what healthcare services were expected, and healthcare services themselves really haven't evolved in response to that. Unfortunately, in particular, the public health services haven't evolved in respect to that. So some of the most innovative work in response to those changes is taking place in the private sector around the world and in New Zealand. Now, that's a shame in my view, because I think it inevitably is quite partial in the way it responds and has some other effects. But that big sort of secular thing is going on. I think the interesting thing about New Zealand is that we actually have the ability to respond more clearly than some other countries do. I think in the UK in particular, the problems of the NHS are probably even more deep-seated than the problems here, and I think that we have, particularly led by what in its broadest sense public health response and involvement of the leadership of Māori health organisations. I think we have if we don't force them to simply ape the old system, I think they have a lot of answers for us in how we can evolve more quickly to a better health system. So I'm not that negative about our opportunities here. I'm just negative about the way the current health sector leadership and government have interpreted it. I think their understanding is shallow.
I do hear that thread of optimism. Despite all of those challenges that you laid out, it sounds as though you still believe that there is a hope of us getting through this crisis.
Yeah, one of the crazy things, I'll probably do a Stuart Nash here, but I wasn't a cabinet meeting. But one of the crazy things that happens is there's a meeting every Monday with the Minister of Health, and ministry people will trot along, and far too many people from Te Whatu Ora go too, because they should be doing their day job, but leave that aside. And they're always asked, how's the system going at the moment? And they always say, it's coping. And it really used to intensely annoy me, because what fucking choice did they have but to cope over the weekend? Were they going to walk off the job and leave people bleeding in the corridor or anything? The system had no choice but to cope. It was kind of a meaningless response, but it reflects an attitude that it's not that bad. Those people are coping with that problem. Meanwhile, I've still got my job. Well, I haven't, but people at the head of the health system have still got their jobs. And I think that again reflects this distance that's felt in the health sector between the people doing the work and the people who are running it.
And that's such a sobering comment, that coping doesn't mean it's okay. Yeah. And
no, that's right. We can't run a system forever on people who are just coping.
And it actually, brings to mind some of the many amazing family carers who I speak with in almost impossible circumstances, who are coping because there is no alternative. And it doesn't mean that what they're living with is okay. And perhaps the same is true for our health system.
Yeah, and I think, a lot of people within the system do understand this, and a lot of people, within organisations like MSD and Kangaroa and others, know that whole combination of things that makes up Paora, or the potential for Paora, are multifactorial, I think is the word that the people use these days. Multi-factor is probably enough, but and that they therefore need that kind of response. So I think we will, because there is that understanding, I think we will evolve to that level of understanding, but there's an unnecessary amount of pain in the meantime, and we've just got to get on and do the things the health system can do.
We're coming into the last minutes of our discussion. 18 months as chair, what are you proud of? What did you achieve in those 18 months that you can look back on and think, yeah, I made a difference there?
Honestly, nothing. I'm a beneficiary of the process of being involved. I learnt so much from the people working in the system and from the Māori organisations that I interacted with, the Pacific Island organisations I interacted with. It's made me, I don't know if it's made me a better person, it's a bit late for that, but it's given me a better understanding of the social issues in New Zealand that I want to keep working on. But frankly, I don't really think I think we've been a great disappointment to date.
And if there was one thing that you could be assured would happen, if there was one change that you knew we would see in the next 5 years, is there anything that feels the most urgent or the most important for you?
Two things. One is have a workforce that actually is genuinely engaged in the process, in their workplace, in policy, and in what's being achieved. Because I think if we don't have that, we won't make any progress. So we've got to activate that workforce through their organisations. That's the first thing. The second thing, because it's so easy, is to develop a genuinely active public health service that is taking on the key public health issues. When I put my economist's hat back on, I'd love to really be able to get to grips with the way CapEx is done in the system, the way political decisions drive what is built and where it's built rather than health factors. But that I think is a lot harder for us to achieve. So if I had to pick, I think I only had one, so I'd pick two. I think workforce engagement and public health initiatives are the two that there's no reason not to do.
Thanks, Rob. I think everyone in the room is listening and nodding and taking those words with them. You've spoken a few times about the importance of public health initiatives and those social determinants of health, and I think you've spoken previously about, for example, the availability of cheap alcohol in Auckland. And it's such a difficult balance, isn't it, between the need for these urgent acute care services and putting the effort into addressing those underlying determinants of health, which is sometimes responsibility lies outside the health sector. Do you feel like we've got that balance right? Do you feel as though the time and the effort and the money that we're investing on acute urgent services compared with addressing social determinants of health is right?
No, I don't. I think it is a both question. I don't think you can abandon secondary, acute health services at the same time. But there is excess money in the system that could be redirected from where it is now to more effective places, and it is always a matter of hard choices. But can I tell you a story that I was standing with the Minister of the Crown at a particular location where one of the tedious announcements was being made about a new building that was going to proceed, which was really just a photo opportunity. And I said to this person, if you took this area and you said, here's all the health problems that the communities in this area have, and here's $1 billion to fix it, would you build a hospital here? And he said no. And we're building a hospital there. So I think we kind of know what we have to do. It's a matter of the political will to do it that's really missing.
Thanks, Rob. You've done a beautiful job of bringing us full circle right back to my very first question about what motivated you to take on this role. And the more that I hear you talk, the more that I think that maybe efficiency and equity are not two separate motivations, that actually if we can find those efficiencies in the system, that perhaps there are resources and money and the goodwill of the healthcare workforce to try and achieve a more equitable system. It sounds as though for you those two ideas are very interrelated, that partly through the efficiency you can achieve those equity gains.
Yeah, that's certainly my view, and I think that it's the only possible conclusion to reach if you actually believe in progress in these things. If you don't, you're not going to endlessly just chuck money at old systems hoping it produces equity when it's previously produced inequity. So the money alone's not the answer. You've got to drive change, and then if you say to yourself, well, how's that change going to be effective? It's highly unlikely that it's going to be effective if it's completely driven from the top down. It has to involve people who are at the flax roots of whatever it is, and involves them and their ideas and building up from there rather than building down. So health is no different, I don't think, to any other part of social change in that respect.
Love that phrase, flax roots change. All right, well that's almost all the time that we've got. Just one final question. It's a slightly personal one. I think many of us in the room will be curious to know what's next for you, Rob, with your sort of incredible wisdom and the experience that you have to bring. Where will you be directing your energies next? Well,
I just want to, actually, a lot of people in this room will know, and Darian Fenton would hate to hear me saying this, but a lot of people here will know Darian Fenton, but she made a comment when all this happened, in a social media post, that what I should do is go back to the ground level and start learning again. And I think she's right, and that's actually what I'm trying to do. So I'm just going to spend some more time back with the people who sort of got me excited about this stuff originally in South Auckland, the particularly the BBM people, but a whole range of other people working in social stuff there. It doesn't have to be very grand, but that's what I think I feel more compatible with. I think I've finally reached the conclusion I'm not a public servant by nature.
Can I ask you all to join me in thanking Rob for his wonderful contribution and comments tonight. Thank you. And thank you all for coming along tonight. I think that these are incredibly important conversations to have. Thank you to the Fabian Society for inciting debate, and to all of you for wanting to be part of these deeper conversations that go beyond 10-second sound bites to really try and understand the importance of the social change. Thank you.